Welcome to Chapter 7, Cerebral Dysfunction. We're going to be going over the Glasgow Coma scale, meningitis, increased intracranial pressure, head injuries, headaches, and seizures. Starting with differences in central nervous system. So the pediatric neurological assessment is not simply a smaller version of an adult assessment. It requires knowledge and developmental milestone and expected age-appropriate findings. What's normal for the infant, like strong primitive reflexes and open fontanelles, would be pathological in an older child or an adult. Your key differences. So, structural development, brain growth timeline. Infancy, the head is the fastest growing part of the body. 50% of postnatal brain growth is achieved by the first year. In early childhood, brain growth is 90% complete. By age 6, 75 completed. I'm sorry. Early childhood brain growth is 90% complete by age 6, and then 75% completed by age 2. With our skull and our fontanelles, infant skull bones are separated at the suture lines with two fontanelles, which are your soft spots. Your posterior fontanelle closes by 2 to 3 months. Anterior fontanelle closes 12 to 18 months, depending on literature. Children and adults, sutures remain open in early and middle adulthood, but our fontanelles are closed. Cortical development, the cortex of children progressively thickens and the sulci deepens as the brain surface area expands. So once we're adults, the cortex has reached full thickness with established sucal patterns. We have some functional differences. So when we're talking about myelination, infants, myelination is incomplete at birth. Spinal cord myelination is almost completed by age 2. And we talked about that when we were talking about GU and how children are not developmentally ready due to this spinal cord myelination for potty training until at least 2. With children, ongoing myelination parallels the development of their motor skills and their coordination. In adults, myelination is complete, allowing for a full motor control and faster neural transmissions. Neurologic assessment. So with infants, neurologic exam primarily detects reflex responses requiring intact spinal cord and brainstem. Much of the forebrain is immature. With children, as the brain matures, infantile reflexes are normally lost. The maturing brain inhibits these reflexes. With adults, voluntary control and complex cognitive functions predominate over reflective responsive. Metabolic activity with children, cerebral blood flow and oxygen consumption are approximately twice that of adults. With adults, there's a lower metabolic demand. And again, think back to, the reason why we're so worried about daily weights and INOs with these kids because we know that these demands are higher, so we need to meet them. Synaptic development, neuroconnections at birth. Essentially, all neurons are present, but the connections are limited. In childhood, we have rapid formation of network connections, and synapses continue from birth throughout many postnatal years. So remember, the key principle with that is the development of skills like walking, talking, and thinking depends on these neurons making connections and myelination of the axons. So, your clinical implications with this. Children are a vulnerable population. So, with our prenatal, early childhood, critical periods during development make nervous systems vulnerable to genetic and environmental factors. So, nutrition, toxins, infections, maternal disease can all impact. When we're looking at our head circumference monitoring, head growth almost always reflects brain growth. Monitoring fontanelles and planting head circumference on growth charts is essential. With reflexes as diagnostic tools, infants We have the presence of age-appropriate reflexes, which indicate normal development in children. If we have these persistent infantile reflexes, it could indicate some type of developmental delay, cerebral palsy, or a central nervous system lesion. Our Glasgow Coma scale. So we need to think what's developmentally normal for the child that we're assessing prior to assessing it. And I believe everybody's had clinical at this point. So you've seen how there's a different clinical tool for assessing a Glasgow Coma scale of somebody less than one versus somebody over the age of one. The standard Glasgow Coma scale can be challenging to use with young children, particularly our infants and toddlers who might not have verbal communication skills. So for the pediatric patients, we need a modified or a pediatric Glasgow Coma scale. What are we looking at? We're looking at the verbal response. So the verbal response is adjusted to reflect age-appropriate communication. With an infant and a young child, we're looking at, are they cooing? Are they appropriately crying? Are they moaning? Or do they have no cry? Rather than orientation of speech. With toddlers, a simple word or sound are considered normal marking rather than a full sentence because they're not going to be articulating a full sentence. In preschoolers, the assessment looks for recognizable words and appropriate responses for the developmental level. Our motor response, remember, motor responses are evaluated, but it has to be based on age-appropriate movements. Infants, spontaneous or purposeful movements withdraw from pain. Assessment considers the normal developmental milestones for them. With eye-opening component, this component typically remains the same across all ages, though stimulus interpretation can vary. And then special scoring considerations. The scoring range remains 3 to 15. Across all ages. We want to always document the components of the score separately. So, what's their eye opening, what's their verbal, what's their motor response, and we're taking the best. Note that children's age when documenting it as a developmental significantly impacts the interpretation. A 2-point change remains clinically significant and warrants provider notification. Now we're going to start moving into some disease processes. So, meningitis. Meningitis is an inflammation of the meninges surrounding the brain and the spinal cord. It can be bacterial or it can be viral. Remember, with bacterial, we need to treat it with antibiotics, and it can also be more severe and life-threatening. So, causative agents kind of vary based on age. When we're talking about bacterial for our newborns, we're looking more usually at like E. coli or group B beta hemolytic streptococci. And those are transmitted from the mother's birth canal during delivery, and it can cause lethal meningitis and sepsis. On our infants, 1 to 23 months, these guys tend to pick up Streptococcus pneumoniae and Neisseria meningitis. Infants younger than 1 are particularly susceptible to the meningococcal disease. Children 2 to 4, again, N meningitis and S pneumoniae, approximately 2 to 5% of healthy children are carriers of the N meningitis. All ages, staph and streptococcal pneumonia, meningitis, associated with neurosurgery, skull fracture, or complications of a systemic bacterial infection. Middle ear, sinus, mastoid infections can all lead to it. We do have some high risk populations, children with sickle cell, status post splenectomy, if they have HIV, if they have asplenia, or some terminal complement component deficiencies, they can get it. So, what does this look like? What's your clinical manifestation? So, we have a prodromal. This often preceded by a respiratory or GI tract infection, and we're going to have headache, fevers, vomiting, and irritability. We do develop some central nervous system specific symptoms, which are always important to know with meningitis, and that's going to be the photophobia, the nuchal spinal rigidity, so neck stiffness. When we ask them to put their chin to their chest, they're usually not able to, and it causes discomfort. We get decreased level of consciousness, and then we can have seizures. So when we talk about classic meningeal signs, the nuchal rigidity, that's that pain and resistant to neck flexion. We do a Kernig sign, and a positive Kernig sign is indicative of this, and that's resistant to knee extension when hips and knees are flexed against the body in a supine position. And then there's also a positive Burdinsky sign, and this is flexion of the knees and hips when the neck is flexed forward rapidly. We can also get some posturing where they get this rigid arching of the back with the head extended. That usually indicates a severe meningeal irritation. Age-specific signs, remember that infants, being that they have those open sutures and open fontanelles, we're going to see bulging of the fontanelles due to increased intracranial pressure. We can also see a petechiae rash. Again, with viral, it's not as severe, but it can be very detrimental to our younger ages. So somehow, right, they got introduced to this virus. It could be direct viral infection, or it could be secondary to a disease like measles, mumps, herpes, or leukemia. The key diagnostic features. We'll have mononuclear response in our cerebral spinal fluid, and then normal glucose levels in the cerebral spinal fluid. Whereas bacteria usually has changes in that glucose. So this will be normal, that'll be not. Clinical manifestations are going to be similar to bacterial meningitis, but again, usually more mild. So if we prevent it by giving the pneumococcal vaccine, that's great. Ages 11 to 12 for the initial dose, and then we can do our booster. Um, so just remember, there's some common misconceptions with this that all children with a fever and headache have meningitis. That's absolutely not true. Remember the meningeal signs like the nuchal rigidity, the positive Burninsky's and Kernig signs. Those should be present. Viral and bacterial meningitis are treated the same. No, they are not treated the same. Bacterial requires immediate antibiotics, whereas your viral is supportive care only. Um, there's a mnemonic of FBI for assessment. We want to assess fontanelles for F, Burdinsky's and Kernig's for B, and then irritability and photophobia for I. So, a little bit more on that assessment. What's your neurological status? We should be doing level of consciousness, monitoring for seizure activity, and these should be, very routine, every hour, every 2 hours, maybe more or less, depending on where they're at in this condition. Vital signs and vital signs to monitor for increased intracranial pressure, which we'll talk about on the next few slides. Definitely a fontanelle assessment in our infants and monitoring for those complications. Key interventions, right? If it is bacterial, we need to make sure we're starting antibiotics. Either way, we want to do infection control. We want to do our isolation precautions. We want to support oxygenation and perfusion. We want to manage the fever. Due to the photophobia and the irritability, it's really important that we're providing a quiet, low stimulation, dim environment. And then we want to do family support and education. So now going on to increase intracranial pressure, because these kiddos can get it. Increased intracranial pressure is a critical condition in which pressure within the skull exceeds normal limits. compromising cerebral perfusion and potentially causing brain damage or death. Normal ranges, typically you don't need to know this, but it's a nice to know that normal is like 5 to 15 and abnormal would be greater than 20. Increased intracranial pressure is measured in the ventricles, the subarachnoid space, the subdural space, the epidural space, or the brain tissue. So the pathophysiology, you know that the skull is closed. Once all those fontanelles close, and it's a rigid compartment containing three components that must maintain relatively consistent volume. So you have your brain tissue of 80%, you have your blood of 10%, and you have your cerebral spinal fluid of 10%. If one component increases in volume, another must decrease to maintain normal intracranial pressure. So when compensation fails, increased intracranial pressure rises. This cycle of increased intracranial pressure. So we have some type of insult to the brain. Something happens to the brain, and then we have tissue swelling. So tissue swelling will increase the intracranial pressure. And at that point, we'll have compression of our ventricles and our blood vessels. Then we'll have a decreased cerebral blood flow, which will lead to decreased oxygen delivery, which will lead to brain cell death, which will then create more edema around that necrotic tissue. Further increased intracranial pressure occurs, and then we'll start to have brainstem and respiratory center compromise. At that point, carbon dioxide is accumulating. We start to have vasodilation, which increases our blood volume, which continues to increase our intracranial pressure, which will potentially lead to herniation and death. So your pediatric considerations. Remember, infants with open fontanelles, that's kind of an advantage because those open sutures and fontanelles allow for some accommodation for volume changes. However, if we see those bulging fontanelles, that indicates that increased intracranial pressure. We want to do head circumference. Daily measurement is essential because abnormal increase may indicate hydrocephalus or increased intracranial pressure. Um, then we have the Monroe-Kelly doctrine, which does not fully apply when the skull is not closed. And that's kind of the factors influencing intracranial pressure. So we have arterial pressure change, venous pressure change, intra-abdominal and intrathoracic pressure, body position and posture, temperature, and blood gas levels, especially your CO2. So, age-related vulnerabilities, cerebral blood flow, and oxygen consumption in children are approximately 2 times higher than that of adults. So twice what the adults do. And that higher metabolic demands means that children may deteriorate more rapidly with this compromised perfusion. So what are we going to see? Our early signs may be a headache, and we might have vomiting. Usually the vomiting is going to be projectile. We might have irritability and restlessness. We might have lethargy, decreased responsiveness. Remember, in the infants, we're going to have those bulging fontanelles and that increased head circumference. Later signs, these are not good signs that your patient's getting to this point. And later signs are going to be decreased level of consciousness, bradycardia, decreased motor and sensory response. We might start to do posturing. Decorticate is when they turn in towards their body. Decerebrate is when their arms and legs turn against their body. Alterations in pupil size and reactivity. If your child once had normal pupil reactivity and now is having abnormal pupil reactivity, that is, something that you would notify a provider about. Are they having seizures? Then we get to the Cushing's triad, which is going to be hypertension, bradycardia, and irregular respirations. Again, some specific infants might have this really high-pitched, shrill cry. They might have setting sun sign where the eyes deviate downward, and that's just from the increased pressure. They can start to have separation of those cranial sutures and then decreased feeding. So what are we going to do? For your nursing assessment priorities, we're going to do that continuous assessment of level of consciousness, pupil size. Are they equal? Are they active? Are they reactive to light? Are they having motor function, right? Because if we have too much pressure in there, the eyes aren't going to be able to move the way they normally would. What's their vital signs? We're going to be paying close attention to trends, right? Are we starting to have bradycardia? Are we starting to have hypertension? What's our daily head circumference measurements? We also want to monitor for some subtle changes. Neurologic changes may be really subtle, especially early on. So we want to document and report even small changes promptly. When we're talking about positioning and handling, the head position. Our head position, maintain an elevated head. We want to maintain a midline position where we keep it in neutral alignment. We want to avoid extreme flexation because this can cause a venous obstruction and increase intracranial pressure. So when we talk about elevated, it's about 30 degrees is where the bed should be set at. Typically 30 degrees or less to help balance that increased intracranial pressure reduction, and then still maintain adequate cerebral perfusion. So we're not going to be doing like a 90-degree head of bed, but like 15 to 30 degree. Movement and care. We want to minimize handling, especially in those high risk infants, like maybe if they're premature or they already have an intraventricular hemorrhage. We want to turn them slowly and gently because rapid positioning changes can increase intracranial pressure. We want to avoid extreme hip flexation. Anytime that we move, really flex and hip and arm, we can raise our intra-abdominal pressure, which then increases our intracranial pressure. But we still need to be turning every 2 hours to prevent complications of immobility. When we're talking about environmental management, we want to reduce stimulation. We want to keep the environment quiet and calm. We want dim lighting. We want to cluster care activities to allow for rest periods. We want to minimize unnecessary procedures. We want to prevent intracranial triggers. So think about, your family-centered care. Think about your atraumatic care. We want to educate the parents. We want to empower the parents. But we want to make sure that, this child's not crying, that they're not having excessive handling, that, we're doing painful procedures with adequate pain control, um, and only suctioning when necessary, because all of that stuff, crying is going to increase their intracranial pressure, painful procedures are going to increase it, too much suctioning. So we need to be mindful and we need to educate. Pain and comfort control. Again, pain control and agitation both increase intracranial pressure. So we want to provide comfort measures. We want to administer, prescribe analgesics and sedations appropriately. Use gentle touch and soothing techniques. We want to monitor for complications. So reflex posturing, that would be the decorticate or decerebrate, may occur as a reflex response. Turning, skin care, passive range of motion can trigger posturing. So we need to continue necessary physical care, but be aware of these triggers. Um, and then I have the little mnemonic here that just kind of gives us, avoid, right? We do not want to do anything that's going to make the child agitated or crying. We want to keep those to minimal. The Valsalva and the hip flexion will increase intracranial pressure, overstimulation, incorrect positioning. And we just want to make sure that we're assessing them routinely because delayed recognition could lead to further deterioration. So lots of patient education, lots of parent education. We need to educate them on the signs of ICP monitoring and interventions, teach signs of what increased ICP will look like in their child. Especially, last week we talked about hydrocephalus. So those kids have the risk that that VP shunt can no longer be long enough or they can have a complication and they need to be aware of these signs so that they can seek medical treatment early. Prepare for potential need for follow-up imaging, address concerns about long-term complication, and encourage participation in comfort measures when appropriate. Head injuries. Um, Head injuries are the leading cause of death and disability in children. The unique anatomical and physiological characteristics of the pediatric central nervous systems create specific vulnerabilities and injury patterns very distinct from adults. So, your epidemiology, leading cause of death in children from unintentional injuries, motor vehicle accidents account for more than half of all injury deaths. Remember, kids need to wear their helmets. They need to be put in a car seat appropriately. Falls are very common with this. Bicycle injuries for 5 to 9 are at greater risk for death as a result from traumatic head injuries. We also have abusive head injuries that account for a significant morbidity and mortality in infants. So when we're looking at our anatomical considerations affecting it, infant specific vulnerabilities. They have a large head to body ratio. Their head is disproportionately large and heavy. They have weak neck muscles and they cannot adequately support or protect their head. There's a large amount of water in the brain, which increases the susceptibility to shearing forces. They have open fontanelles and sutures while providing some accommodations for swelling. They don't prevent serious injuries. Thinner skull bones have less protection for underlying brain tissue. And then the incomplete myelination makes brain tissue more vulnerable to injury. Mechanisms of injury differences, acceleration and deceleration forces are more devastating in children due to those anatomic factors. Rotational forces will cause shearing of blood vessels and neurons. Coup contra coup injuries are when the brain moves within the skull, causing an injury at the impact site, which is your coup, and at your opposite site, which is your contra coup. We have a few different types of head injuries. We can have a concussion, which is just a temporary disturbance of brain function. It leaves symptoms of confusion, amnesia, headache, dizziness, nausea, sensitivity to light and noise. It can have a cumulative effect with repeated injuries. We can have a contusion, which is bruising of the brain. It may cause localized edema and increase intracranial pressure. It's going to be more serious than a concussion. We can have skull fractures, which can be linear fractures. Most common, those usually heal without interventions. If we have a depressed skull fracture, that means that a bone fragment pushed inward. It may require surgery. And then our basilar skull fracture, which involves the base of the skull, has hallmark signs of a battle sign, which is bruising behind the ears, raccoon's eyes, which is bilateral orbital bruising, and then cerebral spinal fluid leaking from the nose and ears. And cerebral spinal fluid leaking from the nose and ears, always a really, sometimes it's a hard one to assess because if the kid's crying, then you're going to see fluid dripping from their nose. So you can't always. But if you take that fluid, um, you take that fluid and you put it on a little piece of gauze, you're going to see a halo sign. And that halo sign is usually like a little yellow halo that comes up. So we can look for that. And then obviously we shouldn't have drainage from our ears. So I think that's a little bit more obvious. Intracranial hemorrhage, we can have an epidural hemorrhage, which is between the skull and the dura. It's often associated. We can do a subdural hematoma, which is bleeding between the dura and the arachnoid. This is really commonly in our abusive head traumas. And then a subarachnoid hemorrhage, which is bleeding in the subarachnoid space. And an intracerebral hemorrhage, which is bleeding within the tissue. We also have abusive head trauma, which is, a serious form of physical abuse by a violent shaking. historically known as shaken baby syndrome. Usually occurs when the caregiver is frustrated from the child crying. Maternal stress or depression can happen. So we have this mechanism of violent shaking, which causes brain rotation within the skull, shearing forces that tear blood vessels and neurons, and this results in intracranial bleeding and a brain injury. Um, so, diagnosis, high probability when three or more features are present. So, we usually see no external signs of injury. May have evidence of previous injury, and symptoms are easily mistaken. Clinical manifestations by severity. So, what are we going to see? If we have a mild head injury, we might have like a brief or no loss of consciousness. We might have some transient confusion or disorientation, some headaches, maybe some nausea and vomiting. They might have a completely normal neurologic exam, but they might not recall the events. So, may have some amnesia of what happened. With a moderate head injury, we're going to have loss of consciousness that's like lasting seconds to minutes, usually persistent vomiting, lethargy, possible skull fracture, and they might have post-traumatic amnesia. More severe head injuries are going to have prolonged loss of consciousness, signs of increased intracranial pressure, neurologic deficits, seizures, abnormal posturing, respiratory complications, and hemodynamic instability. So, assessment priorities. Remember, we want to identify life-threatening conditions first. So, airway, maintain cervical spinal precautions because if you had, a significant head injury, there's a chance that your neck was injured too. We want breathing. So, what's your respiratory effort? How are we oxygenating? Circulation. Are we having any uncontrolled bleeding? We need to control it. We need to assess for perfusion. And then disability is a rapid neurological assessment. So that's going to be, completing your Glasgow Coma scale. And then we kind of move into our secondary assessment where we're looking at, we call it the sample for S is signs and symptoms, A is allergies, M is medications, P is past medical history, L is last meal, and then E is events leading up to injury. Then we want to move on to what is our injury? How far did we fall? What type of surface did we land on? Was it a motor vehicle accident where we just hit the dashboard, or were we not restrained and we flew out of the car? So our head hit the windshield, cleared the windshield, and then hit the pavement. Loss of consciousness duration. Did we have a helmet on? Did we have a protective device on? Our neurological assessment, level of level of consciousness. So what's their most sensitive indicator? Are you walking in the room and they're awake? Or are you walking in the room and doing a sternal rub for them to kind of like groan at you? What's their pupil size? Are they equal? Are they reactive? What's their motor function and strength? What's their sensory responses? What's their Glasgow Coma scale? Are you using the correct scale? 15 is perfect, 3 is the worst. Fontanelle assessments, obviously, if you have a fontanelle, we can assess them. Bulging will indicate increased intracranial pressure, right? And then physical examination. You want to inspect that scalp for any lacerations, hematomas, or depressions. Remember, because if it's a depression, then we might have a depressed skull fracture and we need to possibly get them prepared for surgery. Check for cerebral spinal fluid leak, right? Which is going to be that clear drainage from the nose and the ears. We can do that halo test and see that little yellow ring. Battle sign, which is bruising behind the ears. Raccoon's eyes, which is bruising on the eyes. Those are going to be that basilar skull fracture. Retinal examination if we suspect abuse, and full body assessment for all other injuries. Head injury red flags. So, red flags that require immediate intervention. If we have a decreased or deteriorating level of consciousness, if we vomit two or more times, if we have unequal or non-reactive pupils, if we're starting to have decorticate, which is going towards your core, or decerebrate, which is going away, if we start to see that Cushing's triad of bradycardia, hypertension, and irregular respirations, if we have that cerebral spinal fluid leak from the ears or the nose, if we're having seizures, and then also the significant of mechanisms, right? If you had a kid who fell from a tree house, which is three times their height, that's a big fall. Head injury management. So, first and foremost, preventive strategies, right? Education and anticipatory guidance. If we have a kid and they're going in a car, we need motor vehicle safety. And we did safety a lot in our first few lectures of pediatric nursing, right? We want appropriate car restraints that are the right age and size. We want to never leave the child unattended in or around vehicles and driveway safety awareness. It's really sad when a parent's rushing out to work and they accidentally hit their kid with the car. Bicycle safety, helmet use. Helmet use greatly reduces the risk of head injury. It needs to fit properly, it needs to be properly positioned. Children should be supervised, and obviously, they need to be safely riding away from traffic. Fall prevention, right? Infant safety. They should never be left alone on elevated surfaces. So we shouldn't be setting them up on the counter and then turning away while we're going in the fridge. That's not safe. Safety with gates on stairs, window guards, playground supervision, and then making sure that they're using age appropriate equipment. Abusive head injury trauma, it's really hard for new parents that aren't familiar with it, even parents that have had a kid, but this new one is a little bit more colicky, a little bit more crying. So, lots of coping strategies. Never shake the baby. It's okay to walk away from baby while they're crying. Helmet campaigns for community level prevention, school-based safety education, safe playground designs, and traffic measures can all be community level prevention. Now, nursing management once the head injuries occur. So, the acute management phase, we want to make sure that we're maintaining cerebral perfusion. So, again, head needs to be midline, elevated about 30 degrees. Make sure that they don't have a spinal injury, though, right? So, until they check that cervical spine, we're leaving them flat. We want to avoid neck flexation or extreme hip flexation because that will increase intracranial pressure. We want to prevent activities that increase intracranial pressure, like crying, straining, and the evasive maneuver. We want to do our neurologic monitoring, so frequent neuro checks. This could be every 15 to 30 minutes initially, and then Q2 hours for 2 days. Um, and that's your book. Q2 hours for 2 days. You want to monitor for signs of increased intracranial pressure. You want to document and report changes promptly. And then you want to do your Glasgow Coma scale trending. We also want to prevent secondary injury. So, what does that mean? We want to maintain adequate oxygenation to avoid hypoxia, which can lead to an anoxic event. We want to control any fevers. We want to prevent or treat seizures. We want to manage pain appropriately, and we want to maintain hemodynamic stability. We want safety measures in place for seizure precautions, so padded rails, call bells in reach, suction equipment, things like that. We want to do the family-centered care, so lots of communication, support, and discharge teaching. Also, remember that every nurse is a mandatory reporter, so suspicion of abuse should be reported to appropriate authorities per your facility and state law. You want to document objectively exact quotes, descriptions, inconsistency, and history. And again, this is what you're seeing, not what you perceive happen. You want to provide support to the child and non-offering family members, non-offending family members. Now we're going to move on to headaches. Headaches in infants and children are common complaints. They're uncommon in young children and they warrant thorough investigation when reported repeatedly or worsening severity. The causes can be really benign to something that's life-threatening, so we really need to do a careful assessment and differentiation. So the cause, kids can get primary headaches like migraines, tension headaches, cluster headaches. Clusters are rare, but they can happen in children. Then we can also have secondary headache causes like increased intracranial pressure, infections like meningitis, head traumas, dental issues, and vision problems can also cause headaches in kids. And then we can also have brain tumors. So, headache characteristics, we want to see what's the onset and duration, what's the frequency, are there patterns to it, what's the severity, when's the timing, right? Because if it's in the morning, we might be worried more about increased intracranial pressure. And then maybe if it's in the evening, not as much, right? Because we know when they're laying flat all night long, they can wake up in the morning with a little bit of a headache. We want to know what's the associated symptoms, right? Are they having photophobia? Are they having behavioral changes? Are they having vomiting or nausea, vision changes, things like that? Are there any precipitating factors? Like, do we notice that currently, they get a headache every time they have Chinese food and therefore they're sensitive to MSG? Are they having a lot of stress and emotional factors playing into it? Are we having increased physical exertion? What's our environment like? Are we having lots of lights, sounds, changes in weather? And then with adolescent girls, sometimes menstruation can play into it. What's the impact on their school, on their activities, on their sleep? Are they having social withdrawal? What's their family history? Do they have a parent or a sibling with headaches? Are there other neurologic disorders that run in the family? And then we want to move on to our physical examination. So, vital signs, growth patterns, overall appearance and behavior, complete a good neurologic examination with level of consciousness, cranial nerve function, motor strength and coordination, sensory function, deep tendon reflexes, gait assessments, head and neck assessment, palpate their sinuses, assess for that nuclear rigidity, examine their scalp and skull. We can also check their temporomandible joint. And then additional screenings that we need to do are visual screenings, dental examinations, as well as blood pressure to rule out hypertension. So there's a lot of things that we want to assess for. Headaches, we have some red flags. So sudden onset of worst headache in life, altered mental status or personality changes, neurological deficits like weakness, numbness, and visual changes, morning headaches with vomiting, headaches that awaken the child from sleep, progressive worsening over time, headaches following head trauma, age less than 3 with recurrent headaches, fever with headache and neck stiffness, palpable edema on exam, abnormal neurologic examination, or failure to thrive or developmental regression are all warning flags that we need to investigate further. So, migraine headaches in children. Clinical features, often they're unilateral, but they may be bilateral. It's usually described as a throbbing or pulsating. It might be moderate to severe. It could be aggravated by physical activities. They may have an aura, which is like a visual change, sensory symptoms, photophobia or phonophobia, nausea and vomiting, and a lot of times they'll get relief when sleeping. Dietary, chocolate, aged cheese, caffeine, MSG, artificial sweeteners, and processed meats can all be triggers. Environmental triggers like bright lights, loud noises, strong odors, and weather changes. And behavioral triggers, stress, anxiety, sleep deprivation, irregular meals, and dehydration. Hormonal triggers, adolescent girls during menstruation time. And then physical triggers, excessive exercise, and poor posture. So, our management, We want to make sure that we're doing non-pharmacological interventions, like sleeping schedules, balanced meals, adequate hydration, daily exercise, limiting screen time, especially before bed. Stress management, teach the child how to relax. We can use biofeedback techniques, meditation and mindfulness, and yoga. Environmental management, we want quiet, dim lit environment during our headache times, sometimes cool or warm compress to the head and neck, gentle massage to the head, neck, and shoulders, and minimization of sensory stimulation. Dietary management, if we can identify and eliminate the food that triggers it, that's going to do wonders for them. Pharmacological, we want to do mild as possible. So, acetaminophen is going to be your first line treatment for mild headaches. Nonsteroidal anti-inflammatories can be used like ibuprofen and naproxen. Some over-the-counter preparations combine nonsteroidals with caffeine. Caffeine narrows blood vessels by blocking the adenosine, and that helps. If the child's having some severe migraines, we can start them on some more significant medications. We're not going to go over those though, because you really don't need those. Important considerations, children can suffer from rebound headaches, which can occur after drug relieves the initial migraines. We can also use antiemetics because of a lot of times these kids will have nausea and vomiting with their headaches. And a lot of times they want to use Reglan because it promotes gastric emptying, especially when we have the kid that's getting nonsteroidals. Education is key. We want to preventative therapies. So if we can identify what's causing it, we want to get that on board. We can do a headache diary, which records the date, time, and duration of the headaches, rates the severity, notes activities, foods, or stressors beforehand, documents any associated symptoms, tracks medications and their effectiveness, and identifies patterns and triggers. They should be aware of when to seek medical attention, such as if they're having a headache that's different from the usual pattern, if they're having sudden severe headaches, headaches with fever, stiff neck, headaches after head injuries, neurologic symptoms, so changes of vision, weakness, confusion, if it's starting to interfere with their daily activities, or if they're frequently using their pain medication. Medication safety, they need to know to take the medication as prescribed, avoid overuse of pain relievers, no side effects and when to report, and do not mix medications without provider's approval. And then school considerations, we want to communicate with teachers about the conditions, plan for medication administration at school if needed, arrange a quiet space for the child if headache occurs, and then provide documentation for absences. Seizures. So, seizures are sudden abnormal electrical discharges in the brain that result in involuntary alterations in consciousness, motor activity, behavior, sensation, or autonomic function. They represent one of the most common neurological conditions in children. We have classification of seizures. We can have a generalized seizure, which involves both hemispheres of the brain. We can have a partial or focal seizure, which begins in one part of the cerebral hemisphere. We can have a combined generalized and partial seizure, and then we can have unknown or unclassified or generalized seizures. Um, we can have tonic-clonic, which is considered the grand mal. It's usually 2 to 5 minutes. In that tonic phase, we're having that stiffening and rigidity. And in that clonic phase, we're having the relaxing and the jerking. Associated features with this, they might bite their tongue, they might have incontinence of their urine and feces, and they might become cyanotic. They'll have a postictal state where they're fatigued, confused, lethargic, and that can last an hour. In a myoclonic seizure, we have brief jerking and stiffening, occurs single or in groups. It's just a few seconds. It can be symmetrical on both sides or asymmetrical one side. Consciousness might be present. And we have some complex partial seizures, which is when we have a loss of consciousness where the client blacks out for 1 to 3 minutes. And then they have repetitive, purposeless movements like lip smacking, chewing, picking at clothes, fumbling with objects. Patients are unaware of the environment. They may wander at seizure onset. They will have a post-ictal amnesia where they have a loss of the memory of the event, usually originates in the temporal lobe. The big one for our kiddos, though, is the absent seizures. And these are considered a petit mal. They're common in children. And what happens in the absent seizure is that the child has this brief lapse in consciousness for like 5 to 10 seconds. They kind of have this blank staring, but they have like no loss of posture, so they don't fall. And very often, this can be mistaken for daydreaming or inattention. It can occur many times a day. Usually begins in children ages like 4 to 12. It's usually outgrown in adolescents, and it responds well to medication. Febrile seizures are something all on their own. These are the most common type of seizures in children. It occurs in association with a fever, typically affects ages 6 months to 5 years. Peak incidence is 18 to 24 months. There's a strong genetic component to it. We have a simple febrile seizure, which lasts for less than 15 minutes. Um, they usually do not reoccur within 24 hours, and we have no neurologic abnormalities. When we have a complex febrile seizure, this is going to be greater than 15 minutes. It's reoccurred within 24 hours of the same illness, and it could have some post-ictal neurological abnormalities. And I know at the hospital that I work for, when we have a kid with a complex febrile seizure, a lot of time we admit them. Pathophysiology, exact mechanism is unknown, but we note that it's likely related to a significant rise in temperature. And it's a rapid rise. It's not how high they get, it's how they went from like 98 to 102 rapidly. Brain immaturity and increased susceptibility to fever, genetic predisposition, and cytokine release during infection are all things that are likely related to it. So, our clinical presentation occurring during that rapid temperature rise, often early in the febrile illness, may be the first indication that the child is ill. Um, Temperature, 100.4 to 102.2. Child appears completely well before the seizure. After the seizure, they might be a little sleepy, but they're going to fully recover. Um, Prognosis is usually generally excellent. There is a risk, I guess, of epilepsy that's slightly higher than the general population. Um, Management, we want to make sure that we're treating this seizure. All right, so acute seizure management, making sure that their airway's safe, they're not getting hurt. Obviously, we're going to treat the underlying infection. So if it's a bacterial, we're going to give an antibiotic. If it's some type of virus, then it's just fever management with antipyretics and then supportive care with like hydration, parent education and reassurance. Prophylactic anticonvulsants are generally not recommended for simple febrile seizures, which has to be educated to parents because they'll be like, well, why aren't we putting anything on them? Rescue medication may be prescribed for home use in select cases, but I have not seen that happen. Febrile seizure key facts. So they occur with rapid temperature rise, often a first sign of illness. Reoccurrence risk is about 30 to 40%. Increased risk if first seizure is less than 12 months, if they have a family history, if they have a short fever seizure interval. We want to treat the fever, educate the parents, and rescue meds for select cases. A little bit more on the nursing care for this. Seizure medications, if they decide to start seizure medications, they usually like the child to be on them for a good 2 years without any complications, and then they want to then taper them off. We do not just stop seizure medication. Um, so it's usually tapered over weeks. Managing care during the seizure, we want to make sure that we're staying with the child, protecting them from injury. We do not restrain them. We do not put anything in their mouth. We can turn them to the side when possible to help promote drainage of secretions and help maintain that airway patency. We want to observe and document. So, what was there an aura phase before the seizure? What happened before the seizure, what's happening during the seizure, what's the onset, what's the location, what's their eyes doing, what's their level of consciousness? Are they aware of the environment? Are they responding to voices? And then after the seizure, the post-ictal phase, do we have behavioral changes? Are we sleeping? Are we able to speak? Or do we have aphasia where we're unable to speak? Are we having dysphoria where we can't articulate words? Um, Immediate post care, you want to maintain airway, position on the side, suction if needed, oxygen, recheck vitals, reassess neurologic status. Lots of emotional support, right? We want to reassure the child. We know the seizure can be frightening, explain what happened in age appropriate terms, reassure the families and witnesses that, seizures are frightening, answer questions honestly, assess understanding and address misconceptions, and then provide education about the seizure. Status epilepticus. So this is a medical emergency. Seizures greater than 5 minutes or repeated seizures for 30 minutes without consciousness. So basically, you have a seizure and then maybe it stops, and then you have another seizure and it stops, but you're never regaining consciousness. And note that a seizure greater than 10 minutes can be fatal. So, common causes: sudden withdrawal or noncompliance of anticonvulsants can cause this. Acute illness, infection, head trauma, metabolic disturbances, and central nervous system infections. Priority interventions, always airway, breathing, circulation. We want to position the airway, suction as needed, give oxygen as needed, possibly prepare for intubation. We always need IV access. Our emergency drugs, first line is going to be your benzodiazepines like IV Ativan. We can do IV or rectal volume. We can do IM intranasal or buccal Versed. Second line is going to be the anti-convulsants. So we might do phosphofetin, which can be IV or IM, or we can do phenytoin dilantin, which is IV. We want continuous monitoring of vital signs, oxygen saturation, cardiac rhythms, level of consciousness, monitoring specifically for hypoxia, aspiration, hyperthermia, and rhabdomyolysis. Acute seizure activity, increase in intensity, number, and duration versus what the client's typical pattern is. Is this some type of cluster sequence where we're having rapid succession with and we're treating it with Ativan or diazepam to prevent, a status epilepticus. Patient and family education, supervised during bathing, especially if they're in the shower, because if they go into this and they hit their head, it's a problem. They're not allowed to swim alone because if they're having this and they have an event while they're swimming, they're just going to sink. Avoid heights and climbing, helmets for biking or contact sports. Some providers will not let the child do those, even if they have to be seizure free for a while for that. And that is the end of this lecture. Next will be impacts of cognitive and sensory impairment on the child and family. Thanks for watching.